Hello everyone. Today we will discuss about hyperkalemia. So we consider hyperkalemia when serum potassium levels are more than 5.5. This is hyperkalemia. And if it is more than 6 milliequivalents per liter in serum, we can consider it as severe hyperkalemia. This is the first thing. Then we have to know some causes of hyperkalemia. The thing is, as we all know, kidneys are trying their best to excrete the potassium out of body. So if hyperkalemia is occurring in our body, that indicates either kidneys are not doing their function, or you can think in another way, that is, usually potassium will be intracellular, and if something is obstructing it to enter into the cell, that can lead to hyperkalemia. So I will explain it now. So whenever there is renal injury, commonly in elders or diabetics, CKD patients, ESRD, or those individuals who are on medications which is causing potassium to retain in the body, for example ACE inhibitors or ARBs, potassium sparing diuretics, commonly. So these things are actually leading to increased level of potassium in the body. This is first one. Second thing I told is potassium is intracellular. So potassium is intracellular, but something is obstructing potassium from entering into the cells. So here is the problem. So this is inhibited. What are the mechanisms that are leading to decreased shift of potassium into the cells? Mainly, if there is any usage of digoxin medication or some toxins such as oleander, or even increased levels of protons, that is acidemia, will lead to non-uptake of potassium. Actually, that if there is excess protons, those protons will only enter the cell instead of potassium, leading to increased levels of potassium into the serum. So these are few things. Or sometimes what happens, potassium will be there normally intracellular, but some agents are dragging them out, leading to hyperkalemia. So what are these agents which are dragging the potassium out of cells? So we know that some osmotic agents such as mannitol, 3% NaCl, even increased levels of glucose will drag water out of cells. So along with water, sometimes potassium will also be dragged out. So even usage of these things can lead to hyperkalemia. So these are some causes which we have to know. Again, in these two situations, the thing is, there is no actual rise in the potassium levels, but there is problem in the distribution of potassium. So that is the thing which we have to understand first, because in renal injuries there was actual rise in the potassium in our body. Now we told that we will consider hyperkalemia. So what is the main fear in hyperkalemia? That is cardiac arrhythmias. So that we will see now. So when we see at the cardiac manifestations, that is manifestations of potassium, initially when the levels are between 5.5 to 6.5, this will affect the repolarization of cardiac system. So this will affect repolarization is affected. So we know that repolarization will be indicated with T wave in ECG. So we will see T wave changes. T wave changes at this level. That is, commonly we see tall T waves. So to differentiate it from hyperacute MI, this tall T wave is seen in all the leads when it comes to hyperkalemia, and in specific leads if it is because of the myocardial infarction, and there are some other morphological changes also. That is a separate entity. And after 6.5 to 8 levels of potassium, this will affect conduction of cardiac tissue. That's why it will be presented as PR prolongation, even QRS widening is seen, widening. After 8, like if it is more than 8, this conduction and repolarization is affected so much that it might lead to ES systole or ventricular fibrillation. Even sine wave pattern can be seen. So this is the ECG changes in relation with the serial increase in potassium levels. Now, most important thing is about treatment of potassium, treatment of hyperkalemia. So we have to understand the treatment with the mechanisms. That is very, very important. We all know that we will use calcium gluconate, we will use insulin, dextrose, even nebulization. But the thing is, we don't know the mechanism of those medications. So here we will deal it.